Okay, thank you very much for introduction. Thank you for the invitation. And so I'm going to talk about the medical treatments of venous malformations. Juan Carlos told you a lot already, and we're going to try to get into perhaps more details. So when we talk about vascular malformation, we usually always start with the classification, which has been recently updated. So as everybody knows, we're going to speak about venous malformation that can be simple, isolated, or combined with other malformation and even be part of more complicated syndromes. On this scheme, I've summarized the clinical presentation in which you will find venous malformation. That can be alone, as I said, they can be associated with lymphatic capillary malformations, and they are frequently associated with overgrowth syndrome, and we are going to talk mainly about Klippel-Trenaunay syndromes and Klove syndromes. The great topic nowadays is the ongoing increasing knowledge about causative genes in those entities. It started actually with the venous malformation and the few familial presentations that allowed to identify causative genes, mainly TIE2. Those familial presentations allowed secondly to find out that this gene was also responsible for the sporadic forms. And what is very interesting is that very recently, as Juan Carlos already told you, genes that are involved, and mainly P3CA, in the overgrowth syndromes can be also responsible for a cluster of venous malformation. And this is important. This actual nowadays genotyping is very important for the treatment. So the symptoms, you may know all those information perhaps. The diagnosis is made, as you know, on clinical features with those enlarged vessels that can be located all over the body, on the vulva, but also on the face. It can be little, like on those examples, and the problem will be essentially a cosmetic concern. It can be a little bit wider on the face. Again, the problem is cosmetic, even if it's more complicated with the enlargement of the involved tissue and the lip. More than the cosmetic concern, the venous malformation can be responsible for pain, as you may know, and pain is related usually to the presence of the very characteristic phleboliths within the lesion, as you can see here on the MRI. Sometimes the lesion can be very superficial. It is easy to make the diagnosis on the clinical feature, and you can see on the MRI that the lesion involves only the fat tissue, which is good news for the patient because it will be not so difficult to make surgery for this patient. Sometimes the lesion is visible, but it's not obvious. And when you make MRI, the lesion is much more, it's much bigger than expected, as you can see here. And again, you see the phleboliths that are the main problems for the symptoms in those patients. Another example of a lesion which seems clinically quite small. And actually, when you do the MRI, you see that it's much wider and less accessible to surgery, probably. And again, the characteristic phleboliths on MRI. Here, the problem will be mainly the pain. Sometimes it's almost not visible clinically. The skin is normal, and it's logical because the vascular lesions is within the muscle, very deep inside the leg, so you can't see anything outside but the MRI makes the diagnosis, and those presentations are highly painful. Sometimes it's not wide, but it's very complicated because it's very infiltrative in the muscles, as on those two examples. And you can see with these examples that the interventional treatments are sometimes useless. This patient, she's a teenager. She has been through 2 sclerosis, 4 times surgery, and still, this is the MRI after the treatment. Still, she has the lesion in her fingers, and still this lesion swells and is painful. In those very large vascular limb venous malformations, you may have joint involvement, which is very complicated for the treatment, as in this example. This little girl has many times hemastrosis, which is dangerous for her knee. Even more complicated situation, you know this situation with those multifocal venous malformation on the skin, and a dominant lesion which is here on the anus area, and the gut is filled with other little venous malformation. It is Bean syndrome, which will be responsible for abdominal pain, GI bleeding with blood loss, and iron level lowering. And even more complicated venous malformation are very frequently encountered in P3CA-related overgrowth syndromes, such as Klippel-Trenaunay syndromes and Clove syndromes, as in this example. And they are frequently, they present frequently gut involvement with the same consequences as in the Bean syndrome, with GI bleeding, life-threatening GI bleeding, blood loss, and they have also venous thromboembolism. We're going to talk about it a little bit later. So the idea is to understand why those VMs are so painful and bleed. Those VMs are characterized by large vascular beds within, and within them the blood does not move almost, and this blood stasis is one of the main triggering factor for the coagulation phenomenon to activate and to become almost a self-sustained phenomenon that is sustained by the blood stasis. The blood stasis will activate many different coagulation factors, and the most important is the 10A coagulation factor. This 10A factor will be responsible almost directly for the thrombin generation, and thrombin generation is almost already a change in fibrin, which characterize the thrombosis. The thrombus within the vascular bed is responsible for inflammation, and it is the inflammation which will be responsible for the pain. At the same time, this activation of the coagulation is responsible for the consumption of the coagulation factors that are involved. And the more those coagulation factors are consumed, the less they are available for hemostasis elsewhere in the body. And that's why at the same time you have thrombosis, and you have also bleeding, mostly in the joint and gut, and more largely mucosa locations, but also all over the body if the phenomenon is severe. The biological marker of this so-called localized intravascular coagulation is the elevation of the D-dimer level in the blood. Why? Because the fibrin, at the moment it is generated, it's destroyed, and this destruction leads to the elevation of the D-dimers. Then the D-dimers is the is the biological marker of the severity of the LIC. The most severe the LIC will be, the most elevated the D-dimer will be. And it has been shown in this paper that there is a correlation between the severity, the size of the venous malformation and the location and the depth of the location and its severity. In this paper, they make a score to measure the severity of the venous malformation, and they correlate it to the D-dimer level. And you can see that the wider the venous malformation is, the more deep it is, the more elevated will be the D-dimer. Perhaps it is something very easy for you, but in my practice, I don't found it very easy in my colleagues. This localized intravascular coagulation has really to be differentiated from the KMP. It is perhaps obvious for you, but it is not so obvious when every day. The clinical situation are completely different. We have been talking about venous malformation with those characteristic vascular beds. In KMP, which characterized tufted angioma and KHE, the lesion is completely different in MRI with those very infiltrative lesions. And clinically, it's completely different. You have those venous, soft, venous, enlarged veins, and it's completely different for KMP and KHE, actually, which occurs on huge vascular tumors. The biological features are also completely different, and it has been shown in this paper. Even if in the two situations the D-dimer will be elevated, perhaps the platelet can be lowered in the venous malformation, the mechanism is completely different. You may know that in KMP, the mechanism started with the platelets, which are trapped in the tumor, while in the venous malformation, as I explained it to you previously, the whole phenomenon started with the coagulation factors, and the platelet may be involved, but very late in the phenomenon. To understand it more schematically, I use this scheme of what's happening in true life, in normal life, in slow flow vessels and fast flow vessels. Slow flow vessels characterize venous malformation. Fast flow vessels can characterize KHE and in KMP. As we said, the main triggering factor for thrombosis in veins is the blood stasis. The blood stasis activates the coagulation factors responsible for thrombin generation, and very lately, if the phenomenon is severe, the platelet will finish to be activated, and sometimes they will decrease in number. While in arteries, even in normal life, such as cardiac events, the first event is a lesion of the arterial wall, which will activate the platelets. Then the first actor in fast flow vessels will be the platelets. The platelets are activated, and then secondly, platelets will activate coagulation factors. And this is very important to understand the differences in those two mechanisms, because the treatment will be different. So as I said before, we are at the time of the genetic analysis of those vascular lesions. As I said before, the story started in the venous malformation with those familial cutaneous mucosal venous malformation, which are quite rare, but about 15 years ago, I think, a germline mutation was found to be responsible for those presentation, and it was the TIE2 gene. This identification allowed to find afterwards that the sporadic, well-known venous malformation were also related to TIE2 mutations, but in a somatic pattern, there were actually mosaicism. And more recently, the Bean syndrome, which is characterized by those multifocal venous malformation on the skin, the presence sometime of a dominant lesion, and the gut involvement has also been found to be related to the same gene, the TAI2 gene. Which is interesting, and Juan Carlos already told us, is that a subset of sporadic venous malformation were not found to be related to TAI2 mutation, and actually this subset is related to PIK3CA mutation, which is just downstream TAI2 on the signaling pathway, and this is quite understandable that these two genes can be able to lead to almost the same phenotype. Which is very interesting is that this PIK3CA, which is very famous now to be responsible for the PIK3CA related overgrowth syndromes, is just upstream the mTOR, and then leads to the use, a very interesting use of rapamycin, and we're going to talk a little bit about it. So venous malformation, which are part, and this is very interesting because it is like the extreme of the PIK3CA related overgrowth syndrome. So we're going to talk about treatment. However, despite all this increasing knowledge about mechanism, still the management of those venous malformation remains symptomatic and requires, as we said before, a multidisciplinary approach with the dermatologist, the hematologist, the physiotherapist, the surgeons, interventional radiologists, and using many different kinds of medical or interventional treatment, and the management still relies on a case-by-case basis. If we come back to the scheme of the coagulation, so what we can do? As I said, the first step and the cause of the symptoms is the blood stasis. So as you know, the first step of the treatment will be to give a compressive garment in order to reduce this blood stasis and to reduce the size of those large vascular beds. But sometimes and frequently it is not enough, and patient are still painful. So logically you were going to give classical painkiller, but most of the time it's also not enough. Then you can try to treat inflammation, and anti-inflammatory therapy is frequently quite efficient, but with time, sometimes the patient escape to the anti-inflammatory treatment. Then you are at this step, and the idea is to treat the thrombosis. As I said before, the main actor of the thrombin generation is the 10A factor, and fortunately we have anti-10A agents which are low molecular weight heparin, and when you use low molecular weight heparins such as enoxaparin, but mostly in our team we use fondaparinux, which seems to be more efficient, you will stop this coagulation loop, which increase by itself, which intensity increase by itself, and when you stop the 10A, you stop almost everything. So if you stop 10A, you stop thrombin generation, then you stop the thrombus, then you stop the inflammation, and then you stop the pain. And at the same moment, if you stop this coagulation activation, you will stop the consumption of the coagulation factor. The coagulation factors will be released in the blood and the circulation, and then the bleeding tendency will decrease, and the patient won't bleed anymore with this treatment. So it's a very nice treatment that is able to treat at the same time thrombosis and also bleeding in the same patient. The fact is that there is no prospective clinical trials about the use of this treatment. The efficiency of the low molecular weight heparin relies actually on case series description, and the recommendations that are related to are based on expert opinion in each country. What we know is that the treatment by low molecular weight heparin will be recommended to treat the pain if the previous treatment are not working, but also if you are willing to undergo invasive procedures such as surgery or interventional radiology, in case of active bleeding, such as in Bean syndrome, and also when you don't have those two situations, but the patient has a very severe LIC and has clinical signs of bleeding tendency with hematoma, for example, bruise and a hematoma. The first question is which low molecular weight heparin shall we choose? As I said before, we usually use in our department fondaparinux, which is not the best experience in childhood. I will talk mostly about childhood because I work in the children's hospital, is enoxaparin. Enoxaparin is used for a long time in children for thromboembolic events, even if it's not an approved treatment in France, in Spain, all over the world. But the experience about safety and efficiency is the best with enoxaparin. In our experience, fondaparinux seems to be more efficient, probably because it is its long life its half-life is longer, and probably because it's a highly selective anti-TNA agent, and this may explain why it is more powerful. The second point about fondaparinux, it is that it has a more comfortable use because it's only one injection, whatever the dosage, and there is almost no lowering, platelet lowering with this treatment, so you don't have to check frequently the platelet count. So as I said, none of those molecules are approved in children, but safety data are available in the literature, allowing us to use them in children. So Juan Carlos told you a little bit about direct oral anti-TNA anticoagulant, such as dabigatran, rivaroxaban, and apixaban. The data about the efficiency of those direct oral anti-TNA anticoagulants are quite few. There are several, very few case reports in the literature, such as this one of this woman who has this huge venous malformation on the neck and the back, and she was used to enoxaparin treatment, and she stopped the treatment at one moment. You can see that she has severe LIC because our fibrinogen level is very low, and she had bleeding tendency actually. And in 2012, she had a very severe hemorrhage. She was started with enoxaparin with usual efficiency, but she was fed up with injection, like in children. And then they decided to try rivaroxaban, for example, and the efficiency on the bleeding was good, and was also good on the fibrinogen level. When they decided to lower a little bit the dosage, they saw that it was not efficient anymore. The fibrinogen level lowered, and she started again to bleed. So they increased a little. They increased the dosage, and it was okay. Concerning anticoagulant in children, you can see that none, as I said, has any approval in countries, and that the data concerning safety are enough for enoxaparin here, but for the direct anticoagulant, the new direct anticoagulant, we have very, very few data. There are some clinical trials that are ongoing, as Juan Carlos said, but we don't have enough data. And in France, for example, it's very difficult to use treatments without any safety data in children. Those safety data are coming slowly. For example, we have this very, very little series of teenagers that received 3 days of dabigatran after classical subcutaneous low molecular weight heparin, and there were no problem, and the pharmacokinetics and dynamics were similar to those of adults. But it's a very, very small series with only 9 patients, so data are lacking for the moment. The remaining question also is certainly the safety, but perhaps more than the safety, it is the efficiency. As the efficiency of low molecular weight heparin has been demonstrated on a clinical experience, we don't really know if those direct oral anticoagulants will be as efficient on the LIC, on the painful symptoms, and on the bleeding. And this has still to be demonstrated. I wanted to answer to this question because it is a mistake that is still sometimes observed nowadays. Vitamin K antagonists, oral anticoagulants, are sometimes are used because children are fed up with subcutaneous injections, doctors think that perhaps it will be efficient. Actually, the mechanism of vitamin K antagonist is completely different from low molecular weight heparin. Vitamin K antagonists, they decrease the coagulation factor generation by the liver. So, as you know, in the LIC, those coagulation factors are already too much consumed by the phenomenon. So if you lower them, you will dramatically increase the risk of bleeding for those patients. And the experience showed that even by decreasing a little bit those factors, you cannot stop the coagulation activation. So you are not, with those treatments, you are not efficient on the pain, and you increase the risk for bleeding for those patients. So vitamin K antagonists, they really do not have to be used in those patients. A question is remain also about aspirin therapy. To my opinion, there is not a great interest of aspirin therapy in the treatment of venous malformation. As we saw before, the thrombus in venous vessels is related to coagulation factors activation, and the platelets are almost not involved in the thrombus generation. So it is not logical to use aspirin in venous malformation. However, there is this paper in the literature which is more optimistic on the use. They found that several patients feels improved with aspirin therapy, long-term aspirin therapy, but it's less than a half of patients, and it's a slight improvement. Still, I'm really not sure that it is efficient. To my opinion, the aspirin therapy is mostly useful by its anti-inflammatory properties than its anti-aggregant properties. So let's go through several clinical examples. This little girl, this picture is close to the birth, so she was very little, and the MRI was performed at 1 year of age. You can see this very huge venous malformation of the arm. It is very impressive because it's the venous malformation almost replaced the whole muscle. And this little girl, she's now 5 years old, and she does not have any problem to move her arm. She just have compressive garments. It is very wondering because she had in 5 years only one painful event. It was a serious painful event because at this moment she could not move the arm because of the pain. The dimers were above 100,000. But we managed to relieve the pain only with anti-inflammatory treatments, and she's still very well only with compressive garments. This is to illustrate the fact that the treatment is not only related to the biological parameters, but is related to the symptoms, and it relies on a case-by-case study. This second little girl has a huge venous malformation on the buttock. She had more than 60,000 nanogram per millimeter D-dimer, and at the age of 1 year she couldn't sit properly. We gave her fondaparinux, and it was like a miracle. She could sit 1 or 2 days after treatment was started. And what is nice is that you can see the decrease of the dimer level in parallel of the clinical improvement. And in this patient, surgery was not performed because the surgeons were feared the functional consequences of removing almost a whole muscle here. So she underwent sclerotherapy, and it was very efficient because it allowed us to discontinue fondaparinux, and she's now well with this treatment. In those situations where you have GI bleeding and very severe chronic consumptive coagulopathy, like in this little boy, he was 6 months, 1 year old, with those biological features. He had life-threatening bleeding since the age of 6 months, and he had this very severe LIC. He received now fondaparinux for more than 8 years, and he has no bleeding manifestations ever since. And the pain in his very large venous malformation is more or less controlled. But sometimes anticoagulant treatment is not enough to control the symptoms related to venous malformations, and it has been already said previously, targeted treatment such as rapamycin can be used, and this now the data in the literature are increasing with those studies. And the study of Laurence Boone that showed that the patients with slow flow vascular malformation, including venous malformation, are really improved on the symptoms by using rapamycin when their symptoms escaped to all the previous treatment we've been talking about. It is still a paper from Laurence Boone, and you can see on this table that the patient with this only venous malformation and the patient with venous malformation with a mechanism which is not really known had improving symptoms and also improving LIC with the rapamycin treatment. This efficiency has been demonstrated on mouse model. It's very schematic, but it's more comprehensive. The same team, they provoked venous malformation with mutation, the TAI2 mutation in mouse, and when they give at the same time the rapamycin at this mouse, the venous malformation becomes much smaller. So it is a further proof for the use of this treatment in those patients. This another example of Bean syndrome. I've shown her previously. The peculiarity in this patient is that she was bleeding. She had pain, but her LIC was not so severe. She had like 1,000 and a half. 1,050 nanogram per ml D-dimer. So we thought that anticoagulant therapy wouldn't be efficient on her pain and her GI bleeding. So we started, she had GI bleeding with a severe lowering of hemoglobin. We started rapamycin, and it was amazing how quick the treatment is efficient. In 2 months, she was not bleeding anymore, and the hemoglobin took at least 3 points, and she was not painful anymore. Another example with this patient with the knee involvement, she had multiple hematrosis and a quite severe LIC. She was under anticoagulant and antifibrinolytic, and it was not enough. Hematrosis still happened. And then we added rapamycin, and she stopped to present hematrosis. So clearly, rapamycin has a great interest, to my opinion, on the mucosal symptoms of venous malformation. The last question I wanted to address was the risk of pulmonary thromboembolism in venous malformation. Actually, it's really rare, and it was classically said to be associated with Klippel-Trenaunay syndrome. The truth is that it probably really depends on the type and the features of your VM. This risk is probably due to two features that are needed. The fact that the deep veins of the limb, upper or lower, are distorted and enlarged. And also, you need that the patient has a chronic LIC. If you have those two features, probably you have a real increased risk for pulmonary thromboembolism. And actually, those features are those of the Klippel-Trenaunay syndromes and Clough syndromes. This is another example, a fairing example of venous malformation in the intrathoracic venous malformation associated with vena cava, dysplastic vena cava, and then the thromboembolic events are just near the heart and the lung, and then you may understand the risk of thromboembolism in this patient. But still, there is no real recommendation about how to treat those patients. You have two clinical situations: massive pulmonary embolism and also chronic thromboembolic pulmonary embolism that will lead to pulmonary hypertension. The treatment will rely on a case-by-case basis, and mostly if you have deep and large vessels and LIC, you will discuss long lasting anticoagulant treatment. To illustrate that those events are not so frequent, this is a communication from the last ISVA in Buenos Aires. They show on many patients with Clough syndrome and Klippel-Trenaunay syndromes, those who have a real risk of pulmonary embolism, that pulmonary embolism does not happen so frequently. 7 cases of Klippel-Trenaunay syndrome, 9 cases of Clough syndrome. And almost a half of those patients underwent a surgery previously. So they were a triggering factor, a third reason actually to had this complication. And what I said previously, almost all of them had dilated deep vein, distorted deep veins. This is the last example. This it is not a Klippel-Trenaunay syndrome, but it has exactly the features that are at risk of pulmonary thromboembolism. He has a venous malformation, but will deep vein, dilated deep veins, and also an LIC, and then this patient is going to have long-lasting low molecular weight heparin. It is a teenager, and as he will be quickly fed up with injection, we're going to try in this patient, because it's a quite old infant, child, sorry. We're going to try a direct oral anticoagulant after subcutaneous injection to try to see if the efficiency is exactly the same on biological markers and clinical markers. So in conclusion, the first point is that the functional symptoms of the venous malformation are related to the LIC. The LIC is different for KP. I think it's obvious for everybody. The treatment of the LIC relies on low molecular weight heparin, and the rapamycin is a further treatment when low molecular weight heparin are not enough. Thank you.